Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us learn from our expert on the principles of cancer screening. This session will be discussed by Dr. Maria Diana Aileen Bautista. She is a graduate of the Medicine and Oncology Fellowship Training Programs of the University of Santo Tomas Hospital. She had her clinical observership in breast, thoracic, and head and neck in MD Anderson Cancer Center, Houston, Texas, USA. She is also the recipient of several preceptorship grants by the European Society of Medical Oncology and the recipient of the 2017 International Development and Education Award of the American Society of Clinical Oncology. She currently teaches at the University of Santo Tomas Faculty of Medicine and Surgery and is the head of the Tumor Registry at the Benavides Cancer Institute, University of Santo Tomas Hospital. She is also active in the field of research and is sub-investigator to clinical trials on cancer. Presently, she is affiliated at University of Santo Tomas Hospital and Jose Reyes Medical Center. This session will be moderated by Dr. Kevin Frehil.
Good afternoon, everyone. I am Dr. Maria Diana Aileen Bautista from the section of Medical Oncology to discuss about cancer screening. Screening refers to the use of tests across a healthy population in order to identify individuals who harbor asymptomatic disease. The goal of screening for cancer is to detect preclinical disease in a healthy, asymptomatic patient to prevent adverse outcomes, improve survival, and avoid the need for more intensive treatments. Screening tests have both benefits and adverse outcomes and should be discussed with your healthcare provider. According to the World Health Organization, cancer is the second leading cause of death globally, with breast cancer as the most common among majority of the population, which includes the Philippines. According to Globocan 2020, breast cancer, lung cancer, and colorectal cancer tops the three most common malignancies encountered in the Philippines. This graph shows the estimated number of new cancer cases in the Philippines in 2020. 17.7% of all the new cases were breast cancer, followed by lung cancer, 12.5%, then colorectal cancer, 11.3%. Now, let us discuss about breast cancer screening. Breast cancer comprises the highest newly diagnosed malignancy for 2020 in the Philippines. Breast cancer is principally a disease of older women. 75% of all breast cancers occur in women aged more than 50 years. The female to male ratio is approximately 150 is to 1. It is also a hormone dependent disease. Women without functioning ovaries or who experience an early menopause and who never received combination estrogen or progesterone replacement therapy are much less likely to develop breast cancer than those who have a normal menstrual history. Breast cancer risk is increased in women with early menarche, late first full term pregnancy, and late menopause. These three factors account for 70 to 80% of the variation in breast cancer frequency in different countries. Also, duration of maternal nursing correlates with substantial risk reduction independent of either parity or age at first full term pregnancy. The components of a breast screening evaluation are dependent on age and other factors such as medical and family history, and can include breast awareness, regular clinical encounters, which include breast cancer risk assessment and clinical breast exam, breast imaging with screening mammography, and in some selected cases, breast MRI. The primary purpose of screening women with average risk for developing breast cancer is to detect breast cancer early, to decrease mortality and morbidity associated with breast cancer. Mammograms are probably the most important tool for doctors, not only to screen for breast cancer, but also to diagnose, evaluate, and follow people who have had breast cancer. Safe and reasonably accurate, a mammogram is an X ray photograph of the breast. It reduces breast cancer mortality by one quarter to one third in women aged more than or equal to 50 years. It is more likely to identify tumors at a stage more appropriate for conservative local therapy. Magnetic resonance imaging, or MRI of the breast, is more sensitive but less specific technique. It is recommended for women with genetic risk, those who are BRCA1 or BRCA2 carriers, those who have Li-Fraumeni or Cowden's, Banayan-Riley-Ruvalcaba syndromes, untested first-degree relatives of women with cancer, women with a history of radiation therapy to the chest between ages 10 and 30 years, women with a lifetime risk of breast cancer of at least 20%. Adequate clinical breast exams include the following: upright and supine position during inspection, and palpation of all the components of the breast, that is, lateral medial, from the mid-axillary line to the sternum, cephalocaudal, that is, from the clavicle to the inframammary ridge, the axilla, and the clavicular lymph node basins. Time spent on the palpable portion of the exam is associated with increased detection of palpable abnormalities. A clock quadrant location and distance from nipple facilitates geographic correlation with imaging findings. So, for women not considered to be at risk for familial or hereditary breast cancer, an evaluation of other elements of risk that contribute to an increased breast cancer risk is recommended. So, this includes demographic factors such as female, the age, ethnicity, and race. There are multiple risk assessment calculators to determine a woman's risk for breast cancer. Different calculators have different factors and should be tailor fit to individual based on applicability. So here are some examples of these calculators. So the Gale model provides a 5-year and lifetime estimate of risk of invasive breast cancer. The Gale model is best used for individuals over age 50 years who have either no family history of breast cancer or one affected first degree and who have annual screening mammograms. The Tyrer-Kruzit model, in addition to considering a woman's risk for BRCA mutation, also estimates her risk of developing breast cancer using not only family history, but also epidemiologic variables, including a personal history of atypical hyperplasia and lobular carcinoma in situ. If the physical examination is negative in an asymptomatic woman, the next decision point is based on risk stratification. Women are stratified into two basic categories of risk for the purpose of screening recommendations. That is an average risk and an increased risk. So when you say average risk, that is when you have less than 15% lifetime risk of developing breast cancer. Increased risk are for women who have a lifetime risk of more than or equal to 20% as defined by models that are largely dependent on family history. So let's go to the average risk. Women with average risk between the ages of 25 and 39, the NCCN or the National Comprehensive Cancer Network recommends a clinical encounter. It includes an ongoing breast cancer risk assessment, risk reduction counseling, as well as clinical breast exam every 1 to 3 years. And of course, encouraging women to be aware of their breast and to promptly report any changes to their healthcare provider. For women with an average risk when they are 40 years or older, The NCCN panel recommends an annual clinical encounter and an annual screening mammography. For the increased risk, we will discuss this one by one. So now let's discuss increased risk subpopulation. So women who have a lifetime risk of more than or equal to 20%, as defined by the models that are largely dependent on family history, it is recommended that you have a clinical encounter every 6 to 12 months to begin when you are identified as being at increased risk, but not prior to age 21, an annual screening mammogram to begin 10 years prior to when the youngest family member was diagnosed with breast cancer, but that is not prior to age 30 or age 40, whichever comes first. It is recommended that you have an annual breast MRI to begin 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to age 25 or age 40, whichever comes first. You also consider risk reduction strategies and breast awareness. If you have received thoracic radiation therapy between the ages of 10 and 30 years old, when your current age is less than 25 years old, an annual clinical encounter is advised beginning 8 years after radiation therapy and breast awareness. If your current age is more than 25 years, you are encouraged clinical encounter every 6 to 12 months, which begins 8 years after radiation therapy, an annual screening mammogram, also beginning 8 years after radiation therapy, but not prior to age 30. You also recommend an annual breast MRI beginning at or 8 years after radiation, but not prior to age 25. You also consider a whole breast ultrasound or a contrast enhanced mammography for those who qualify for but cannot undergo MRI. You consider risk reduction strategies and breast awareness. For women who are aged more than or equal to 35 years, with 5-year Gale model risk of invasive breast cancer more than or equal to 1.7, clinical encounter every 6 to 12 months, an annual screening mammogram, consider risk reduction strategies, and breast awareness. If you have a history of lobular neoplasia or atypical ductal hyperplasia and a lifetime risk of more than or equal to 20%, you're encouraged clinical encounter every 6 to 12 months, an annual screening mammogram. You consider an annual breast MRI. You also consider risk reduction strategies and breast awareness. Now let's go to lung cancer. So lung cancer comprises the second highest newly diagnosed malignancy for 2020 in the Philippines. The estimated number of new lung cancer cases in the Philippines in 2020 is 19,180, accounting for 12.5% of the total cancer cases. 5-year survival rates for lung cancer are only 19%, partly because most patients have an advanced stage lung cancer at initial diagnosis. Ideally, effective screening will lead to earlier detection of lung cancer and will decrease mortality. Currently, most lung cancer is diagnosed clinically when patients present with symptoms such as persistent cough, pain, and weight loss. Unfortunately, patients with these symptoms usually have advanced lung cancer. Early detection of lung cancer is important opportunity for decreasing mortality. Although tobacco smoking remains the primary cause of lung cancer worldwide, approximately 60% of new lung cancer cases in the United States occur in former smokers, many of whom have quit decades ago, or never smokers. Moreover, 1 in 5 women and 1 in 12 men diagnosed with lung cancer have never smoked. Given the magnitude of the problem, it is incumbent that every internist have a general knowledge of lung cancer and its management. Lung cancer screening is appropriate to consider for high risk patients who are potential candidates for definitive treatment. Remember, chest x ray is not recommended for lung cancer screening. All current smokers should be advised to quit smoking and former smokers should be advised to remain abstinent from smoking. Individuals exposed to secondhand smoke have a high variable exposure to carcinogens, with varying evidence for increased risk after variable exposure. Therefore, secondhand smoke is not independently considered a risk factor sufficient for recommending lung cancer screening. In candidates for screening, shared physician and patient decision making is recommended, including a discussion of the benefits and the risks of cancer screening. So, lung cancer screening with low dose CT scan is a complex and controversial topic with inherent risks and benefits. So, results from the randomized National Lung Cancer Screening Trial showed that screening with low dose CT decreased the relative risk of death from lung cancer by 20% in a select group of individuals with high risk factors, such as a history of heavy cigarette smoking. So, looking at the slide, the risk of lung cancer screening includes a fetal detection of a small aggressive tumors or indolent disease. There is anxiety of test findings, physical complications from diagnostic workups. There could be false positive results or false negative results, and there is unnecessary testing and procedures, radiation exposure, cost, and incidental lesions. But the benefits will include a decreased lung cancer mortality. There will be an improvement in the quality of life. There will be reduction in disease-related morbidity, reduction in treatment-related morbidity, improvement in healthy lifestyles, reduction in anxiety or psychosocial burden, and there could also be discovery of other significant occult health risks. So here, based on the risk stratification, it could either be high risk or low risk. High risk when you are aged more than or equal to 50 and you have more than or equal to 20 pack years smoking history. Low risk if you are aged below 50 and has less than 20 pack years smoking history. In the group 1, initial screening with low dose CT is a category 1 recommendation, recommended for patients who are 55 to 77 years with a 30 or more pack year history of smoking tobacco, who currently smoke, or if former smokers have quit within 15 years. It is category 2A for those who are 50 years or older with a 20 or more pack years history of smoking tobacco, who either current or former smokers with at least one additional risk factor. Here you can see an example. If there is a lung nodule on your low dose CT and there is no suspected infection or inflammation, you have to classify if this nodule is a solid nodule, a pre-solid nodule, a non-solid nodule, multiple non-solid nodules, because based on this, it will guide us on what to do next. If in your lung nodule or low dose CTs and you suspect an infection or inflammation, you repeat the low dose CT in 1 to 3 months. If there is no lung nodule seen, you are recommended to have an annual screening of low dose CT. Now, let's go to colorectal cancer. We will discuss colorectal cancer, which is the third highest newly diagnosed malignancy for 2020 in the Philippines. Most colorectal cancers arise from adenomatous colon polyps that progress from small to large polyps, then to dysplasia and carcinoma. Adenomatous polyps occur in 30% of men and up to 20% of women. A polyp in the colon must be biopsied to determine its pathology because gross appearance does not reliably distinguish adenomatous polyps from your hyperplastic polyps, which are typically not precancerous. Progression from adenoma to carcinoma is believed to take an average of at least 10 years. Studies recommend maintaining a healthy weight, eating a healthy diet, and being physically active, as these measures are strongly associated with decreased colon or colorectal cancer risk. Other analyses have shown that adherence to guidelines promoting physical activity and a healthy diet are associated with reductions in the incidence of colorectal cancer. Some studies also suggest that a diet high in fruits and vegetables is associated with a decreased colorectal cancer risk. In addition, some data also suggest that a high body mass index is associated with an increased risk for colorectal cancer, its recurrence, and mortality, but some data are not consistent. Studies also recommend a low dose aspirin intake for primary prevention of cardiovascular disease and colorectal cancer in adults aged 50 to 59 years who have more than or equal to 10% 10-year CVD risk, are not at increased risk for bleeding, and have a life expectancy of at least 10 years, and those who are willing to take low dose aspirin daily for 10 years. The incidence of colorectal cancer was significantly higher in current or former smokers compared with lifelong non smokers. The risk of colorectal cancer also decreased with longer time since cessation and earlier age at cessation of smoking. Increased alcohol consumption is an established risk factor for several malignancies, including your colorectal cancer. The NCCN guidelines for colorectal cancer screening stratifies patients into three groups, depending on the risk of getting colorectal cancer. Colorectal cancer risk assessment in persons without a known family history is advisable by 40 years of age to determine the appropriate age to initiate screening. Now let's go on discussing the different risks. So average risk and an increased risk. So for the average risk, that is when you are at the age of equal or more than 50 years of age, there is no history of adenoma or C-cell serrated polyp or colorectal cancer, no history of inflammatory bowel disease, negative family history for cancer or confirmed advanced adenoma or an advanced SSP. Epidemiologic reports suggest that the incidence of colorectal cancer may be on the rise in adults younger than the age of 50, supporting the rationale to start screening before the age of 50 years old. And for the increased risk, when you have a personal history of adenoma or SSP, colorectal cancer, inflammatory bowel disease, or a positive family history. So when you are considered to be an average risk of developing colorectal cancer, the following are advised: colonoscopy or a stool-based, high-sensitivity guaic-based or immunochemical-based testing, fit DNA-based testing, flexible sigmoidoscopy, CT colonography. When you undergo colonoscopy and there is no polyp seen, you screen with any modality in 10 years. But when a polyp is seen in colonoscopy, you undergo polypectomy. For stool-based, if you do high-sensitivity guaic-based or immunochemical-based testing and it is negative, you rescreen with any modality in 1 year. If it is positive, you undergo colonoscopy. For fit DNA-based testing, if it is negative, you rescreen with any modality in 3 years. If it is positive, you undergo colonoscopy. For flexible sigmoidoscopy, when no polyp is seen, you rescreen with any modality in 5 to 10 years, and you undergo polypectomy if a polyp is seen. For CT colonography or CTC, when a polyp is seen and it measures 6 to 9 millimeter, and only 1 to 2 polyp is observed, you undergo CTC in 3 years or you undergo colonoscopy. If there is more than or equal to 3 polyps seen, you undergo colonoscopy. When a polyp is seen which measures more than or equal to 10 millimeter, you undergo colonoscopy. But when your CTC is negative, you rescreen with any modality in 5 years. So now let's go to increased risk. That is when you have a personal history of adenoma or SSP, when you have colorectal cancer, when you have history of inflammatory bowel disease, and you have a positive family history. So, you are considered to have a low risk adenoma wherein colonoscopy is advised to be repeated 5 to 10 years. That is when there is less than or equal to 2 polyps seen, which measures less than 1 centimeters. When there is no dysplasia or there is less than or equal to 2 polyps measuring less than 1 centimeters, you are considered to have a low risk SSP and colonoscopy is advised to be repeated after 5 years. You are considered to have a high risk SSP when there is a traditional serrated adenoma, high grade dysplasia, adenoma or SSP measuring more than 1 centimeters, when there is villus or tubulovilus polyp, when there is 3 to 10 adenomatous polyps or SSP, colonoscopy after 3 years is advised. But when there is more than 10 polyps, you have to consider polyposis syndrome. So when you have a personal history of colorectal cancer, remember that there is a high recurrence rate 4 to 5 years following resection. For rectal carcinoma, a local recurrence at the rectal anastomosis occurs in 5 to 36% of patients. Rate of second primary colorectal cancer is especially high in the immediate 5 years following surgery and adjuvant chemotherapy. It is advised that a complete colonoscopy preoperatively and at 1 year following surgery be done. If this examination is normal, colonoscopy should be repeated in 3 years, then every 5 years. If you have a history of inflammatory bowel disease, risk factors for dysplasia in patients with IBD are the following: ulcerative colitis, extensive colitis, colonic stricture, primary sclerosing cholangitis, family history of colorectal cancer, especially those diagnosed less than 50 years of age, personal history of dysplasia, and a severe long-standing inflammation. NCCN recommends colorectal surveillance by colonoscopy initiated 8 years after the onset of symptoms. If you are positive for primary sclerosing cholangitis, you're advised annual colonoscopy. If you have a positive family history, wherein one affected first degree relative with colorectal cancer at any age, you are advised colonoscopy every 5 years, beginning 10 years prior to the earliest diagnosis in the family, or age 40 years at the latest. When you have a first degree relative with a confirmed history of advanced adenoma or advanced SSPs, colonoscopy at the relative's age of onset or age at 40 years at the latest. So here are the following syndromes wherein you are considered as a high risk for developing colorectal cancer. So those with Lynch syndromes, polyposis syndromes, Cowden syndrome, P10 hamartoma tumor syndrome, Leaf-Romani syndrome. Cancer screening saves lives. Screening is one of the most effective ways to detect early signs of cancer. It has never been more important to make sure your screening is up to date. Talk with your doctor about when and how often you should be screened. Remember, early detection saves lives. Thank you.
In the next session, let us learn on how to approach and manage anemia. This session will be discussed by Dr. Flordeluna Mesina. She is a clinician and researcher at Cardinal Santos Medical Center and University of Santo Tomas Hospital, and is an assistant professor of the departments of pharmacology and medicine at the University of Santo Tomas Faculty of Medicine and Surgery. This session will be moderated by Dr. Kevin Frehil.
Good day, everyone. Thank you for inviting me for the Tiger Postgraduate course. This is a case-based discussion on anemia. So I saw this patient last December. He is a 60-year-old male who was referred because of anemia. He was a diagnosed case of non-small cell lung cancer stage 4 with liver involvement last October 2020 and was started with chemotherapy, paclitaxel, and carboplatin. He has exertional dyspnea and easy fatigability since then, relieved by rest. He reported also of occasional minimal blood sputum. There are no GI symptoms, no changes in stool color and character. Prior to the cancer diagnosis, he was allegedly healthy, no maintenance medications, and no other chronic illnesses. Family history is positive for hypertension. These are the laboratories he brought. His first ever CBC platelet count in so many years showed a normocytic normochromic anemia with a hemoglobin of 7.8 grams per deciliter, a normal white blood cell, differential count, and normal platelet. He was then transfused with 1 unit pack RBC during the first cycle of chemotherapy. The November CBC are as follows. This is the second cycle chemo. The hemoglobin is 9.2 grams per deciliter and hematocrit of 0.31, normal WBC and platelets. And last December, the hemoglobin was down again to 8.5 grams per deciliter and hematocrit of 0.28. The creatinine of this patient is consistently normal. The physical examination showed a relatively tachycardic patient. This patient is at rest. Um, the the conjunctiva was pale. There are no lymphadenopathies. There are no hepatosplenomegaly. These are the clinical questions for this case. One is, what's the cause of the patient anemia and how to pragmatically diagnose and manage this patient? So this is the algorithm for anemia. It has not been changed and there are no new tests for anemia. The basic tests are inexpensive and should be requested for all patients with anemia. We have the reticulocyte count, the peripheral blood smear, and of course the RBC indices on the CBC. So according to the algorithm, after a good history and physical examination, look at the reticulocyte count and compute for the RPI. If the RPI is less than 2 and the RBC indices are low, these are the microcytic hypochromic anemias. The most common cause would be iron deficiency or thalassemia. If the MCV is high, we have the macrocytic anemias. The most common cause would be folate deficiency or B12 deficiency or the non-megaloblastic anemias. If the RPI, on the other hand, if the RPI is more than 2, this means there's an adequate bone marrow response. Hence, the anemia may be due to hemolysis or bleeding. For the normocytic normochromic anemias, they are the most challenging because there are a myriad of diseases that can cause this type of anemia. So for our patient, I'm thinking on the line of cancer-associated anemia versus the occult GI bleeding. So the algorithm may sound simple, but some patients would have more than one cause. It's not mutually exclusive. Hence, we have to determine the primary contributor. So going back to the patient, the peripheral blood smear showed the normocytic, moderately hypochromic RBC with an isocytosis, no abnormal white blood cell, and platelets was adequate. He has an inappropriately low reticulocyte at 1%. The normal is 0.5 to 1.5%. When the RPI was computed, it was low. Hence, this is a hypoproliferative anemia, which may be caused by low substrate for erythropoiesis and with a peripheral smear of moderately hypochromic RBC. Hence, I requested for iron studies, or the low RPI may be due to bone marrow dysfunction or suppression. So let's go back to the iron studies. It showed high ferritin, 521 nanogram per ml. Serum iron is 20, TIBC is 150, but the computed TSAT is 13.33%. That is low. The FIT or FOBT is negative. So what is the Cause of the patient's anemia. Is it A, anemia of chronic disease or inflammation? B, blood loss? C, bone marrow infiltration? Or D, is it something that will encompass all of the above? We term as cancer associated anemia. For the epidemiology, cancer associated anemia has a prevalence of 90% among cancer patients receiving chemotherapy, but we must remember that it can occur independently of therapy as part of the evolution of cancer. In fact, there are 77% of men and 68% of women cancer patients who are not undergoing chemotherapy but have anemia. So it is important for us to recognize if anemia occurred before treatment or during treatment or after treatment. Advancing age is a factor and also the different cancer type. It is most commonly seen in lung malignancies, gynecologic or genitourinary cancers, and of course the gastrointestinal malignancies. What is the impact of anemia in patients with cancer? Most of these patients will have fatigue. In fact, it is recognized as the most distressing symptom, hence, it will impact quality of life negatively. Second, anemia, of course, is a dose limiting toxicity in many of the chemotherapeutic regimens. So ultimately, it will significantly reduce the patient's adherence to chemotherapy. And then third, anemia can worsen tumor hypoxia or can worsen tumor hypoxia, favoring disease progression and metastasis. Thus, it is a negative prognosticating factor on disease progression, survival, and overall death risk. Cancer anemia is simply defined as anemia seen in malignancy and during its treatment. So we follow the WHO definition of anemia based on gender and the US FDA Common Terminology Criteria for Adverse Events, or the CTCAE, which offers a grading on this cancer associated anemia. So our patient is grade 3. Initially, the patient has a hemoglobin of less than or equal to 7.9 grams per deciliter. There are several mechanisms for cancer associated anemia. One is blood loss that would lead to absolute iron deficiency anemia, where there is low total body iron stores. Second, there can be hemolysis, where there is decrease in RBC survival. It can be immune mediated or non immune mediated. And third, it may be due to ineffective erythropoiesis, where there can be iron block mediated by hepcidin or we call iron restricted erythropoiesis. And lastly, bone marrow infiltration by the cancer cells. So, with regards to the management of this patient, we have a 60-year-old male who is a diagnosed case of metastatic non-small cell lung CA receiving paclicarbo. The baseline lab showed inappropriately low reticulocyte count and iron stores. Can we use ESAs and should we give iron? So, from the recent guidelines on how to treat cancer anemia, patients are classified into um, patients with possible absolute iron deficiency anemia versus those with functional iron deficiency anemia or iron overload based on ferritin and TSAT. So our patient belongs here. He has a relatively high ferritin but low TSAT, hence there is functional iron deficiency anemia. In these patients, IV iron challenge is potentially useful. Let us now compare oral versus IV iron administration. Oral iron, the advantage is that it is inexpensive, it's readily available, and does not require IV access. The limitations, though, are the GI side effects, which can affect compliance to the treatment and variable GI tract absorption. For the dosing requirement, um, the requirement would be 200 milligram elemental iron per day. So the usual ferrous sulfate 325 milligram tablet contains 65 milligram elemental iron. Hence, it would need 3 to 4 times a day. If there is no increase in hemoglobin after 1 to 3 months oral supplementation, you have to reevaluate the patient or shift to IV iron. Let's now talk about IV iron. It resolves the concern about adherence, the efficacy, and problem with absorption because it's directly given intravenously. It may be given 200 milligrams IV administered repeatedly or a single high dose 500 milligrams up to 1000 milligram. For our patient, again, IV iron is potentially useful. And then once the TSAT is improved but anemia persisted, then a bone marrow biopsy is warranted and a trial of ESAS or erythropoietin. Regarding the use of ESAS in cancer patients, according to the latest ASCO and ASH guidelines on the management of cancer-associated anemia, ESAs can be offered in patients whose treatment is not curative in intent. So this includes metastatic or stage 4 advanced cancer patients with hemoglobin less than 10 grams per deciliter. The recommendation is strong and the evidence is of high quality. ESA should not be given to cancer patients with non-chemotherapy associated anemia. However, it can be offered to patients with low-risk MDS with a level of EPO less than 500. And for patients with hematologic malignancy like myeloma, non-Hodgkin's lymphoma, or CLL, hematologic response after chemotherapy should be observed first before considering ESAs. This is because the risk for VTE is already high at the outset. And if we would give erythropoietin, it can increase the VTE risk further. Hence, blood transfusion should be considered first in these patients. This table will show us the dosing guidelines or guidance for both erythropoietin alpha and darbepoetin alpha, both of which have similar safety and efficacy, but EPO alpha is more readily available. The initial dose is 150 units per kilogram subcutaneous 3 times a week, and it can or 40,000 units per subcutaneous weekly. You can increase the dose if you have not achieved a hemoglobin of at least 1 gram per deciliter after 4 weeks of therapy. Okay, or you can decrease it 25% from the baseline if you have achieved a hemoglobin increase of more than 1 gram per deciliter in 2 weeks' time. And then you may discontinue if after 8 weeks of erythropoietin therapy, there is no response to treatment. So one important consideration in using ESAs is the risk of VTE. Again, our cancer patients are already at risk, and so we should carefully weigh the risk versus the benefit. There are several meta-analyses and RCTs consistently reporting 50 to 75% increased risk of VTE and vascular arterial events in cancer patients receiving ESAs. Thus, they recommend the use of risk scores such as the Padua prediction risk score. And unfortunately, there are no available data from RCTs investigating the use of anticoagulants and or aspirin or antiplatelets to decrease the risk of VTE in cancer patients on erythropoietin. So aside from from the patient's cancer, it is important to take note that the chemotherapy itself, which are carboplatin and paclitaxel, especially the platinum compounds, they are toxic to the bone marrow and can induce anemia. Okay. It's more common in hematologic malignancies, but it can also be seen in patients with solid tumors. there are profile of patients or the characteristic of patients that are predictive of chemotherapy-induced anemia are as follows. Those with poor response to iron treatment, advanced age, presence of metastases, the degree of hemoglobin decrease within the first month of treatment, the tumor type, and the treatment duration. Platinum-based therapies such as cisplatin, carboplatin, and oxaliplatin are directly toxic to the bone marrow, and it can also affect the production of erythropoietin due to its nephrotoxic effect. So the management for CIA is red cell transfusion, ESAs, and iron supplementation if needed. So in summary, cancer-associated anemia can be part of evolution of cancer or cancer treatment. And we've discussed the mechanisms of cancer anemia. It's usually multifactorial. We have blood loss, ineffective erythropoiesis, and hemolysis, and also bone marrow infiltration. We should also be able to recognize that most of our chemotherapy regimen can worsen anemia, and thus we should be vigilant. And lastly, be judicious in the use of blood transfusion. Treat the patient and not the numbers. So with that, I'd like to thank our fellow, Dr. Maureen Comia, for helping me put together all the things in the presentation. And thank you for listening. I'm ready to answer your questions.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.